Hello viewers, we are going to discuss some of the orthopedic disorders of the hand here, and there are a lot. 3 of these 7 are more commonly seen in sports injuries. However, the rest can happen in any of us. We'll do a quick anatomy review just to kind of get up to a competent level, and then we'll talk about these disorders. But most of the time we're going to be kind of reviewing the anatomy while we're talking about the disorders here. So the hand, and these are 2 pictures. This is looking at the palmar aspect, and this is looking at the posterior aspect. So you can see that there are tendons that come through, and these tendons are coming from the flexor muscles of the forearm, and they come through, most of them going through the carpal tunnel, and they will then send their projections to the lumbrical, past the lumbricals and to the fingers. You also have muscles in your hand, most of which are responsible for the movement of your thumb. However, you also have some muscles in your forearm that are also responsible for the movement of the thumb. Knowing where each of these are and what their names are is not important for the USMLE. And then this, the dorsal aspect of your hand. Here you also have tendons. Alright, that's about as much as I want to belabor this. These are some motions that the thumb can make. The thumb has a unique joint in that it can make motions that the fingers can't. The fingers can flex and extend. They can abduct and adduct, but they can't do some of these other things that the thumb can do. So here you've got flexion and extension of the finger. I would pay most attention to this extension of the finger. It's going to play a big role in one of the disorders that we're going to see. There's also a palmar abduction, anteposition versus retroposition, radial abduction, palmar abduction, and so forth. So you don't need to know what all these motions are. Just be aware that the thumb is a very mobile joint, and because of that, it's prone to injury. Okay, DeQuervain's Tenosynovitis. So DeQuervain's Tenosynovitis is an overuse injury. It's caused by inflammation on the lateral surface of the first metacarpal. And the reason, okay, so what is the lateral surface of the first metacarpal? Think anatomic position, palms facing out. First metacarpal is your thumb. So the lateral surface would be like the lateral part of your thumb and first metacarpal. So that surface of your hand. And why would you be overusing that part of your body? Well, think for instance, something like this. Look at how she's holding her baby. She's holding her baby with a thumb out, fully abducted, and with her hand cradling the baby's head. And she's probably holding the baby like this for a significant period of time, quite often. And there's 2 ligaments that become aggravated when these muscles that are responsible for putting the hand in this position, when those muscles are constantly flexed, and those would be the extensor pollicis brevis and the abductor pollicis. So what happens is that over time, with this overuse, holding the hand with the wrist flexed and the thumb fully extended, you can get inflammation. And that inflammation can then result in this pain. And this pain is on the lateral surface of the first metacarpal. So right around the lateral part of where your thumb is and your first metacarpal bone. Patients are going to present with an aching pain, of course, along that lateral surface of the hand. And a lot of times these are going to be new mothers. However, there is an increased incidence in pregnancy, so we're not really sure what that's caused from, possibly changes in hormonal levels. But what I tend to see on the USMLE is the new mother vignette. And that's just simply because of the way that they're holding their baby. There is also an increased incidence for DeQuervains with rheumatoid disease as well. So the symptoms that they present with is going to be an aching pain along the first metacarpal, which is the tendon, holds the tendon of the extensor pollicis brevis and the abductor pollicis. And the pain is often aggravated by turning motion. So for instance, turning a bottle of soda to open it, that could aggravate the pain. The patient might also describe a catching or a snapping motion when moving their thumb, and there might be a little bit of swelling present along the area that they describe as painful. The best thing about DeQuervain's tenosynovitis is that we've got a great test for it, and we can pretty much rule it in if the test is positive. And this is called the Finkelstein's test. And if it's positive, you've pretty much diagnosed DeQuervain's tenosynovitis. So here's just another look of what we got here. Here's our two muscles, extensor pollicis brevis, abductor pollicis longus, and they form this common insertion here, and it goes underneath the extensor retinaculum, not to be confused with the flexor retinaculum, which would be on the other side. That's part of our carpal tunnel. But if the thumb was abducted, you could see that it would be stretching this tendon. And if the tendon becomes stretched, then you're bound to have inflammation. So this is Finkelstein's test. And what you do for Finkelstein's test is you tell the patient to make a fist, but put their thumb into that fist. So see here how this guy, here, this is the patient here on the left side. He's got his thumb inside his fist, and then his four fingers making the fist motion. So it's not a normal fist, it's a fist with the thumb inside the hand. And now what the clinician is doing is he's ulnar deviating the hand. So when he ulnar deviates the hand, what he's doing is he's pulling on that common tendon of extensor pollicis brevis and abductor pollicis. And if you pull and stretch out a tendon that's inflamed, of course you're going to cause pain. And so this is Finkelstein's test. So put your thumb into a closed fist and then ulnar deviation. And this is another look. Here's the ulnar deviation here. Thumb into the closed fist. It's the best way to diagnose this. And this is the position. The thumb fully extended, wrist a little flexed. That's causing significant stress on that tendon. It's cute though. So what do we do for these patients? Well, as far as diagnosing them, we don't need to do anything other than clinical, and that's mostly because what we do for the treatment is really nothing significant. The best initial therapy for DeQuervain's tenosynovitis is a steroid injection, which would be injected roughly around where that ligament is. So the best initial therapy for DeQuervain's tenosynovitis is steroid injection, not steroid pills, not steroid IV, steroid injections. And this is how it's done. So they drew down to where that joint is, and they're going to go in, not exactly right there, but they'll stick the needle in past that and get the steroid in that way. And there's usually also an anesthetic in there as well. Now, I'm going to note as well, this is not going to be the right answer on the USMLE, but like a splinting or a casting, that might also be useful for these patients, since they have a tendency to put their hands in positions that are causing their symptoms. So sometimes braces and stuff can be useful too. But for the USMLE, steroid injections are the best treatment for DeQuervain's. Okay, trigger finger. So when you get a trigger finger, what are we dealing with here? Well, we're dealing with the tendons, And we're dealing with these little sheaths that form over the tendons, sort of on each bone. And these sheaths, normally the tendons will slide right underneath them, no problem. When you get an inflammatory nodule, and this can happen for many different reasons, suddenly it's going to become a lot more difficult to slide underneath that sheath. So that when your tendon is lengthening, so for instance when you're extending your fingers, this little nodule is going to get stuck beneath this sheath, and it won't be able, in this case your ring finger won't be able to fully extend. So you'll get stuck. And that's what the trigger finger is. So it's caused by a nodule on the tendon, and what happens then is the finger gets stuck because the nodule won't allow the tendon to go through that sheath. Okay, hopefully I described that physically enough. Okay, so this is a catching due to nodules along the flexor tendon, and this results in sticking beneath the tendon sheath, and then the finger becomes stuck when attempting extension. So even though you're trying to extend that finger, you're just going to be stuck in this position, and that's why it's called a trigger finger. However, if you apply enough extensor force, then you can usually apply enough force to get that nodule to slide underneath that sheath. And usually what that means is that the patient is going to have to take their other hand and just pry open the finger, and just apply extensor force from the other hand. And that's obviously very alarming to these patients. So the history of these patients, sudden locking of the finger when extending the finger from a flexed position, most frequently this happens in the middle of the night or after inactivity. Anything overnight inactivity, that gives time for inflammation to get worse. So any kind of inflammatory disease, just in general, the rule of thumb, any kind of inflammatory disease is going to be worse in the morning. So this frequently happens in the middle of the night or after inactivity, female preponderance, and yes, there's an association with rheumatoid disorders. With these patients, when they come in, they're going to have the characteristic history, locking of finger when extending from a flexed position. Often it's associated with some degree of mild pain, and you should be able to palpate the nodule over the affected finger. However, not being able to palpate a nodule does not rule out the diagnosis. The diagnosis is clinical, and the best initial treatment for trigger finger is steroid injection, and you're going to be injecting this right around the metacarpal head of the affected finger. So here's a patient with trigger finger. They've tried to extend all their fingers. All these fingers are working properly, but right up here, there's a inflammatory nodule that's not allowing this tendon to slide and extend the finger as properly. And right here is where you give the injection. Jersey finger. So a jersey finger is a common sports-related injury, and it makes sense because, well, first off, what's happening with jersey finger? When you have a jersey finger, what you're getting, this is an injury of the tendon, this is an injury of the flexor tendon, but what you're doing here, look at what this guy is doing. These are my beloved Minnesota Vikings, probably losing here, as they always do, but he's grabbing this guy's jersey. No coincidence that this is called jersey finger. He's grabbing this guy's jersey, but this guy is going to run off. And once this guy falls down and this guy with the ball here runs off, it's going to apply a lot of extension force on his fingers because he's grabbing with a flexed grip. And once the guy gets away, it's going to quickly extend his fingers. So these fingers are about to get fully, if not hyperextended. And that will result in damage to the flexor tendon. Remember, the flexor tendon holds us from going too far into extension, and our extensor tendon holds us from going too far into flexion. So you can think of them as sort of having their counterbalance forces that way. But if you go too far into extension, you're going to damage your flexor tendon, and that's what a jersey finger is. So the jersey finger is damage to the flexor tendon of a finger. The history is going to be a forceful extension of the fingers resulting in damage to the flexor tendon, and this is seen frequently in tackle sports like we just saw, or in children doing whatever they do to play. Symptoms are going to be pain with flexion of the finger. Now think about it, your flexor tendon is the tendon that's damaged, so what motion is going to hurt? Well, of course it's going to be flexing, because that's activating that flexor tendon. And so these patients will hold their finger in extension. So pain with flexion of finger due to injury of flexor tendon. If it's a child, they're often going to resist passive flexion. Oftentimes there's going to be point tenderness over the affected finger, especially if the tendon is totally ruptured, in which you'll get inflammation, etc. The diagnosis here is clinical. So based on the patient's history, based on the symptoms, just this clear case of them not being able to flex their finger, or having severe pain with flexing their finger, that points towards a jersey finger. And the best initial treatment for a jersey finger is to splint the affected finger to allow the flexor tendon to heal. In the meantime, NSAIDs can be used for pain management. And so here is a jersey finger. You can imagine if it happened on the other finger, it would look like he was giving you an obscene middle finger. But this guy would really like to flex his fingers, but unfortunately this flexor tendon is damaged here. And so because it's been damaged, flexing it is going to be painful, and this is the jersey finger. And it happens because pulling on somebody's jersey can cause that. Okay, mallet finger. So this is kind of the opposite here. So a mallet finger happens due to an injury to the extensor tendon. And normally this happens due to trauma, particularly athletes who are going to go catch a ball. If you think about it, when you go to catch a ball, especially if you're doing it at the spur of the moment, like these guys going up to get a rebound, they're putting their fingers in, but maybe their fingers aren't totally extended for them to catch the ball, and they might stub their finger into the basketball, which may be moving pretty quickly. And so if you stub your finger into the basketball, kind of like this guy stubbing his finger into the baseball. I don't know how that's happening, but either way, if you stub your finger into the basketball like that, you can rupture the extensor tendon. And normally when you get a mallet finger, it is this very, very distal part of the extensor tendon where this happens. So damage to the extensor tendon of the finger. And the history is either forceful flexion of the fingers, resulting in damage to the extensor tendon, or it is direct trauma. And this is seen frequently in catching sports or in, like I said, direct impact to the flexed fingers. What will the symptoms be? Well, with extension of the fingers, there's going to be some abnormalities. So because the tendon is damaged, you're not going to be able to hold that finger in a correct position. So I want you to see what this looks like. So this is normally where the injury happens. So it's at the distal, very distal part of the joint, distal interphalangeal. And the way it looks is just this sort of flexed finger. Everything else is normal but this flexed finger. If you were to try to put this into the position that the rest of the finger's in, patient would probably try to kick you in the balls. Okay? So again, the best initial treatment for mallet finger is splinting of the affected finger. NSAIDs can be used for pain and management. So jersey finger is an injury of the flexor tendon of the finger. Mallet finger is an injury of the extensor tendon of the finger. And as you know, whenever you have an injury to one tendon, the opposite result happens. So if you have an injury to the flexor tendon, you're going to see some extension. If you have injury to an extensor tendon, you're going to see some flexion. And indeed, with the mallet finger, with the injury to the extensor tendon, the flexion we see is usually in these fingers, because that's the most common place for the injury to happen. I mean, think about it. These kids are going up to catch a ball. It's probably going to be their fingers that are going to get closest to the ball. So right here. Okay, Gamekeeper's thumb. Since we don't have a whole lot of Gamekeepers anymore, this is old. We have a lot of skiers, though. I figured I would refer to it as skier's thumb as much as possible. However, Gamekeeper's thumb is the traditional name for this, and it's still commonly used in medical practice. So briefly, I want to talk about some of the anatomy here. So here's the first metacarpal, and the first metacarpal is stabilized to the proximal phalanx by a number of ligaments, but the most important one, two of the most important ones, are the ulnar collateral ligament and the radial collateral ligament. Now you might be wondering, why are they called that? Just think of it this way. Ulnar is pinky side, radial is thumb side. So the ulnar collateral ligament is just the ligament that supports the thumb on the pinky side, so the side closer to the pinky. And then the radial is on the opposite side. So when you have this injury, when you fall down on a fully extended thumb, so you have your thumb fully extended and you fall down, what's the direction of the impact going to be? The direction of the impact is going to be outwards. So the thumb is going to be pushed out, and the hand is going to be sliding down. And so what happens is you get this tearing of this ligament right here. And this is the ulnar collateral ligament of the thumb. So Gamekeeper's thumb is damaged to the ulnar collateral ligament of the thumb. The history is usually a fall or direct blow on the medial side of a fully abducted thumb. So important, it's got to be on the medial side of the thumb, not on the lateral side. So this would be the lateral side of the thumb. This is the medial side. And it's a fully abducted thumb, and that opens the gate to damage to that ulnar collateral ligament of the thumb. And the result is damage to that ligament. And just to mention, the ulnar and radial collateral ligaments of the thumb, they stabilize the thumb during abduction and adduction at the metacarpal phalangeal joint. So the symptoms of Gamekeeper's thumb would be laxity at the metacarpal phalangeal joint of the affected thumb. Of course, pain, swelling, possibly ecchymoses, just because there's so many arteries and arterioles around there. And that may go all the way down to the thenar eminence. And of course, these patients are going to have difficulty with grasp, since what do we use for grasp? We use our thumbs. So these patients will have difficulty with grasp. Whereas some of those other patients with the jersey finger and mallet finger, they might not have difficulty with grasp, because you don't need all four of your fingers to grasp. They're helpful, but what you do need is your opposing thumb and at least a couple fingers. So these patients will have difficulty with grasp, since they won't be able to use their thumb appropriately. For diagnosis, the best initial step in management is an X-ray of the affected thumb, and this is done to rule out other injury. It takes quite severe injuries to get Gamekeeper's or skier's thumb, particularly skier's thumb. And so it's going to be really important to rule out any kind of fracture that may have happened. And because if there is fracture, then that needs to be addressed separately. The best initial management for the gamekeeper's or skier's thumb is usually casting. However, in severe tendon ruptures, surgery may be necessary. So here's another picture. And so this patient had to fall out with this thumb extended, so pushed away, and then this was where the impact was, right here. Probably this distal interphalangeal joint may have pulled the proximal phalanx, and that could have also led to some tearing. Hard to say. Okay, let's move on to something completely different. So the felon. Not that felon. That felon. So a felon is an abscess in the pad of the finger. And about half of patients who have felons will recall some kind of puncture injury to the affected finger, like wooden splinters or minor cuts. Some of them may be gardeners or working outside with wood, but the other half may not have any significant history. So you can't go by history alone. Felons can also develop as extensions from paronychiae, and paronychiae are infections of the nail bed, bacterial infections of the nail bed. What are the symptoms in these patients? These patients are going to be in some pretty severe pain. So severe throbbing pain in that finger, that's the only place it is. Maybe some edema, you saw some edema in this one. Redness, you saw some redness in this one. And it may be associated with fever too. The diagnosis is clinical sometimes. However, let me rephrase that. The diagnosis is clinical. However, in severe cases, you may want to get imaging because surgery may be a necessary option. So for the lesser severe cases, the diagnosis is clinical, and the reason why we say a clinical diagnosis is because the treatment, we want to do that treatment as quickly as we can. So the treatment is emergency incision and drainage. And you want to make sure that you've fully drained the felon, which is it's really just an abscess. And then the patient should be on oral antibiotics and pain control. The number one cause of a felon is Staphylococcus aureus. Now, of course, if it's a very, very severe case, like I would say this one would probably be a really severe case, then you're probably going to have either surgery down there right away, or you may be able to get by with doing an MRI. I don't expect you to get asked anything like this on the USMLE because that would be more of a surgery board's question. For a felon, most of them they'll look like this. So obviously not an acutely problematic condition other than you want to drain the pus. If this doesn't get drained, it might turn out looking like this. So, for the USMLE, if you have a felon, do an incision and drainage, as well as oral antibiotics. Okay, Dupuytren's contracture. So this is Dupuytren's contracture, and Dupuytren's contracture is a contracture of the palmar fascia. This has a tendency to occur in older men, particularly of Scandinavian descent, and I've seen probably 4 or 5 cases in my 2 years in Minnesota, just because we have a very, very high occurrence of high population of Swedes and Norwegians and Finns and Danes and Icelanders. So this is something quite common up here. But this is very stereotypically seen in older men of Scandinavian descent, and Also, patients with family history. So what is this? This is just a chronic idiopathic fibrosing disorder, and it affects the palmar fascia. And what happens is, because the palmar fascia becomes more fibrosed, it sort of just shrivels up. And as it shrivels up, it pulls the fingers in with it. What will you see out of these patients? They're going to have a difficulty or possibly even an inability to lay their hands flat on the table. Now, lay your hand flat on the table. I'll lay mine. Okay, you should be able to lay your entire hand flat on the table. This guy can't. If he laid his hand flat on the table, it looked like he was hiding something underneath his hand. The diagnosis here is clinical. And the best treatment for Dupuytren's contracture is surgery. This is not something that can be managed with steroids or with any kinds of injections or with physical therapy. Surgery is going to be the necessary treatment. Other things that you can see are these sort of pits. You might see some pits and some nodules. You should be able to feel some nodules, and then there'll be these pits. It'll be just, in general, it would be an unusual hand geography. So here's another one. This guy's trying to lay his hands flat on the table, but he can't because he's got fibrosis in his palmar fascia. Here's another one. Here, again, you can see maybe some nodules, maybe one here, maybe one here, definitely some pits here, and it's just pulling his hands into a flexed position, and the treatment is surgery. Okay, so just to recap. So DeQuervain's tenosynovitis tends to happen in pregnancy due to an overuse injury, also seen in new mothers. The symptoms are going to be pain, aching on the lateral aspect of their thumb, first metacarpal. The diagnostic test is Finkelstein's test, and that is diagnostic. Treatment is a steroid injection. Trigger finger, higher incidence in patients with rheumatic diseases, higher incidences in females. Symptoms is going to be locking of the finger, especially after rest. Diagnosis is clinical. Treatment is steroid injection at the metacarpal head. Remember there, we've got this nodule, inflammatory nodule. We want to calm it down so that the tendon can move through smoothly. Jersey finger is a hyperextension of the flexor tendon, and it's usually due to some kind of traumatic event. Because of the hyperextension of the flexor tendon, you have damage of the flexor tendon, and this is going to result in an inability to flex or pain on flexion. The diagnosis, based on the history, symptoms, physical exam, is going to be clinical. The treatment is splinting. Mallet finger. This is caused from impact trauma to the extensor tendon, and this will result in an inability to extend the finger, or pain on extending the finger, or you just may see this sagging fingertip like I showed you. Diagnosis here, again, clinical. Treatment, splinting, just like jersey finger. Jersey and mallet finger are kind of like twins. They're just a little bit, they're just the opposite. Gamekeeper's thumb. When it's skier's thumb, which I would imagine you're not going to have many gamekeepers in your practice, you'll probably see more skiers. This is due to a direct impact or fall on an abducted thumb. And the symptoms will be laxity at the thumb, metacarpophalangeal joint. Diagnosis, this is going to be also clinical, and you may get an x-ray if you think that there's a severe injury, if you think there may be any fracture involved. But the best treatment for skier's thumb is casting. The Felon is caused usually by a puncture, wood splinter, nails, and so forth. It may also be spread from paronychiae, which is infection of the nail bed. The symptoms will be throbbing pain and edema, erythema of the affected finger pad. You really should just do your triage here. If it doesn't look that bad, then you can go right in, get the emergency IND. If it looks really bad, then you might want to get imaging and get surgery on it. But I don't expect you to get asked that question on the USMLE. I'm mostly just giving you advice for real life. Dupuytren's Contracture, older male, Scandinavian ancestry, family history thereof. Symptoms: inability to lay hands flat on the table. You'll also see, when you're doing your physical, pits and nodules on their palm. Diagnosis here is clinical, and the treatment is surgical. And if you have any questions, feel free to let me know.